Welcome to the second edition of the NurseVerse podcast. This is a podcast organised by the European Specialist Nurses Association, and I am Paul Walsh, and I'm delighted to be joined by Joséfine Declaye, Policy Officer at ESNO and an ICU nurse. Joséfine, how are you today?
I'm great.
So, what we want to talk about is the experience of nurses, and in particular today, the experience of ICU nurses, and then how we need to work with policymakers in order to convey the right messages about that type of experience. So we want to talk about your experience, and how did you get started as an ICU nurse?
I studied right after my study. So in Belgium, you have to do three years of basic nurses, and then you do specialization. So after my specialization in emergency and critical care, I got a job in the ICU. So I followed the course of that. So I did job in other wards, but I mainly worked in the ICU with other element like the volunteering for the Red Cross and stuff. That whole build. Me as a nurse, and that's what got me to the ICU.
Was becoming a nurse something that you always wanted to do?
I don't think so, no. It was something that frightened me because of back in the days, like I seem like old people, but it was like the nurse would do the coffee for the doctors. It was more like, I'm telling you what to do and you do it. So it was not something really sexy in the development of the reflection or the autonomy of it.
Yep.
And then what changed my mind, if I'm critical about it, it's how I volunteer for the Red Cross, and I started to get to patient and see what nurses actually do, and also where some loved ones were sick, I could see really and experience the relief that nurses provided. Like, they will help. They're connected, so and they ease the critical situation. So that was really something, and so I changed my mind. I think that's a good sign, and I really, really love it. And yeah.
What made you specialize in ICU?
I think I like the stress and the intensity or the adrenaline. I need to keep learning and to have a new day every day, but also some grounded issue. But I wanted to connect with my patient and to have some autonomy. And so when you specialize, it's in Belgium, it's the department and the ICU for the critical care specialization. But what made me choose critical ICU, it's like the thing you can build with your patient and their family, their loved ones. Like, you don't only have a patient for like 5 minutes and then you have to do critical action. You can do critical action and then build the trust, build the relationship, and see them get better or help them and relieve them.
How is being an ICU nurse different from other specializations?
So I know my stuff. So in the ICU, we are always seen like really technical, and we are, because now with the technology and the knowledge we have in medicine, we can almost add how do you say it? Like, you can use a machine to restart the heart. You can use a machine so that you don't need a heart to live. You don't need lungs to live. You don't need anything to live, actually. So how far do you go?
So it's the emphasis on technical specialization.
I really like the technique at first, but also the things you can build, like the autonomy of it.
Yeah.
You can adapt your machine, but you can also, you see one thing, it's complex, and then you act on what you see, and you build a plan of care.
Yeah.
So that's what's really nice also.
But there's probably a bit more of a long-term focus. Like, you have the opportunity to develop relationships with patients that you wouldn't, for instance, in the emergency department.
Yes, and you have the outcome.
Yeah.
It's also something that doing some emergency pre-hospital care as a volunteer, that's something also that you don't get. You go to the patient home, you bring them to the hospital, and you don't know what happened.
Yeah.
In the ICU, you know at least that either they leave the ICU good or bad, or they don't leave.
Yeah. Do you think that ICU nurses generally feel empowered, supported to perform their work to the best of their abilities?
I think it really depends on the unit and the management that's taking place, the collaboration with the doctors and stuff like that. It really depends. As association, we are trying to build that strength and to build that confidence in their own strength and their academic thing. More and more nurses are doing PhD, which is great. And it is not something that, when I thought of my image of nursing, when we talked about earlier, like, yeah, it's not really a nice job. I didn't know that it would PhD in nursing. So we also need to work on that.
Let's say somebody from hospital management came to you and said, I want to set up an ICU department in a way that supports ICU nurses in the best possible way. What advice would you give them?
I would say I'm a nurse in the ICU, but I'm not the only nurse. So you should gather everyone and then use data. My stepson, he's playing football. He have this thing that he puts on his chest, and then after the match, he can show me, oh, I ran 10 kilometers, I touched the ball 8 times. How come our ICU are not designed with the how many steps we take to get one syringe to the room? Is the pharmacist in the middle of the ICU is a good idea or bad idea? How come the data that we could have on a soccer field is not available in our hospital facilities? This is, I don't know why. And maybe sometimes I'm thinking like we need to be more of less human in some aspect, like really pragmatic and data, so that we can enhance and create space, create time to get to be human for our patient.
Okay.
You know,
okay,
like
fine.
To be really like, okay, I order something on Amazon. I have more info than my patient that is still in the department and that is gonna come to the ICU. How come the data that is it's not fluent?
So you're losing time sometimes due to inefficiencies, and that prevents you from being able to give the right personal focus to the patient.
Yeah, of course. Or say, okay, for example, like the fibroscope, like it's a camera that you put into the lungs that you can go and watch and remove mucus and stuff like that, so people are breathing really better because, you know, if the airs go in and out, it's a good sign. If it's stopped, it's not a good sign. So it was broken, and then you don't fix it in the weekend. But the patient, they don't leave on Friday night. The job is still to be done. So you're like, okay, but what's happening? The nurse will do it. We'll fix it. We'll go to the other part of the hospital to clean that fibroscope. But it takes time. It's like 20 minutes in, 20 minutes out. You're not to your patient. And you don't need really any academic knowledge to put the machine, the fibroscope in the machine. But it's like, so to answer, like, nurses are not the only thing in the ICU, but they are really important. And to build the best ICU, I think we need to focus on the work we're doing. And don't forget that the patient is the main job of a hospital. It's not the management, it's not other thing. Our core business is taking care of people. And if you focus on that, I think it's a good first step.
Right. And does that not happen?
I don't have the feeling of that. I think it's my own experience. It's really difficult to don't see the hospital as an industry, or we need to make business. The thing needs to be cashable at some point, but we also need to address the issue that it's healthcare. It's not. We're not supposed to make millions of hospitals, you know. So yeah, focus on the care and the experience of the patient, and like the visiting hours and stuff like that. So there's plenty of things.
You mentioned that before you started, you had this image of nurses, this classic image, as being perhaps second-class citizens in a medical environment. How close is that image to reality? And has that changed, do you think, over the past 2 or 3 decades?
I think it changed, especially during the COVID. We were really a lot of clapping for us, which it was really nice. But now it seems like it's forgotten at some point. For the citizens, every time we speak to people like, oh, you're a nurse, it's good, it's a great job, I couldn't do it. It's like they're really tough and stuff. But then you see the legislation, like you don't really have a high pay raise or something like that. Like at some point we make a joke, we said, okay, maybe we should quit and go, I don't know, sell bread or something, because if the bread is not in the right order, the patient won't die. So that's a joke sometimes we make. Oh, we're going to open a restaurant. At least we'll have fun. But we have fun in the ICU also. I forgot your main question, sorry.
But it was this question about the evolving appreciation and reputation. Because we're talking about medical professionals that are really peers to other medical professionals, yes, and not their servants or their assistants.
Yes. Yeah, so the image really changed for me in my comprehension, because once I experienced being a nurse, it's different. Mm-hmm. I think I got the chance to get a placement in the UK. Yep. So the image of nurses is also different, the respect. Also with the S now, I get the chance to meet other nurses from all over Europe. And the representation and the respect they get is different. But sometimes I still think maybe for young nurse, they really follow what the doctor says. They don't criticize it. And I'm really sad about it. Like, come on. Do you understand what she or he asks you to do? Are you okay with it? Then why do you do it? If you're not okay with it, you have your expertise, you know your patient, we are really close to the patient. They come in the room, they see them 20 minutes, 30 minutes if they have time, because the workload for them is really, really high also. But for us, we have like 3 patients, which is really high also in nights, and on days it's 2 or 3, depends on the activity. So we are really connecting. And when you wash someone, you provide like the basic care, you also connect, and they share things with you, like personal things. I think they wouldn't have shared it with other. It's sometimes funny when they say things about their wife or their husband, and then they come to the visit and say, okay, it's not that happy. Yeah. You know, that convenience, not convenience, but that bond that we make, it's really nice and it's really important.
Do you think that regulations that impact nurses properly take account of their experiences?
So that's a regulation shouldn't take more of the experience of nurses to do. Yeah, I think so. If we take the example of Belgium, we have like on the 8th of May a law passed, saying that in the hospital law, that nurses and assistant nurse are the same. They are under the name nurses. So it's not good. It's coming back way before, and then the specific care that we can provide as nurses, the autonomy in our act, can now be delegated to other professionals. So you don't have your own expertise. I would say it's really abstract but if you do a dressing, if I if I teach you how to do vaccination, you could actually do it afterward. So what's the deal? Like, you don't really need nurses if we can just give that permission to do. So.
And that brings us to, as well, the emphasis on continuing education, development. What could be done to ensure that that really becomes part of, let's say, the ethos of a healthcare system?
And it's the empowerment and the speak up for yourself. Like, but we need to have like, sorry, I keep touching. We need to. One main aspect that could be done by the legislation would be address the ratio, the nurse-patient ratio. Mm-hmm. Data provide that if you put more patient on one nurse, mortality rise. So this has been proven. While I was still studying nursing, so it's more than 10 years, and nothing changed. Nothing changed. They're just saying that nurses and non-nursing assistants can be. The data, they say, okay, if you raise the level of education, mortality drops. They don't do it. The law just passed to the opposite, in the opposite direction. It's like, how come the data that's been provided can't be translated to policy? And I think that's why I'm here. This is the storytelling part. This is how I see patient, how I see family, and how I see the care that we cannot provide because of time. And that's really get on the burnout of nurses. That's where we need to match things and change.
So what are you doing to speak up about these type of issues?
So I'm involved with the ESNO and also for the CIS Nursing, which is the Association of Critical Care Nurses in Belgium. And that's my way to handle that thing that I can't stand when I'm in the wards. Because I don't feel, at least on my own experience, that's the place where I can change things. I can change things for one patient and I can handle a few, but if you really want to make a change, it won't happen in one ward. You need to spread it in different wards. So you need to advocate for her strength, for her ratio. If you have 3 patients and they are critical, you need to be more than one to take care of them. And now the ratio are there. But if you take the hospital with the economic aspect, you say, okay, the law says 1 to 3 for the ratio. I'm good. How? Why would I put more nurses? The law says it's good. Yeah, I know, but no.
It's not about using the law as the maximum, let's say. It's the minimum. It's the starting point.
Yeah, it's a minimum. But I know that when you're in a crisis, and we are in a health crisis because of the lack of resources and the money, so it's understandable. I understand it. Sorry. But I don't think it's the right issue.
So you're a nurse, and now you're an advocate for nurses as well. And I think for anyone who's advocating for any particular group, it's extremely important to have a small number of very clear messages. What are yours? I mean, you've mentioned the ratio, nurse-patient ratio before. Mm. What else are you talking about when you're talking to regulators and politicians?
Yeah. There's not a nurse. The nurse doesn't exist, really. That's something we really want to emphasize on. If we make a comparison of teacher, we wouldn't ask a math teacher to teach French or to teach Spanish. Yeah, he's still a teacher, but the math teacher doesn't speak Spanish. Okay, why do we expect that from nurses? The ICU, it's this home bubble. This is my bubble. I love my bubble. But I can't go into pediatrics or geriatrics, even though we have some of those patients. I'm not specialized in that thing. So I have small understanding of it. Not quite small, but I have some. But I'm not specialized. So we need to understand and value the specialization of the knowledge we go. The care are more and more complex. The patients are more and more complex. We live older and older. We get sicker and sicker. So we need to be specialized and stop trying to mismatch things and compare a lot.
So by valuing these specializations, do you mean having them very clearly written into regulation and having that standardized across the EU?
across the EU would be a great thing.
Even in Belgium?
Well, even in Belgium. But I think the right way to go would be to start small and to have a plan. For example, the EFCNA, they published something. So the EFCNA is the European Federation of Critical Care Nurses Association. And they provide position paper on sustainability and way other stuff. But being part of the EFCNA, what I witness is that we have so many different levels, even in the basic nurses. So once you're talking about specialized nurse, it's really difficult to harmonize it as a union. But if you provide core competency for the ICU, the critical care, then you can allow every school to start to teach those, and then a government to start and move them. The European directive for I think it was the 2015 that changed the nursing in whole Europe. Now in Belgium it's 4 years. It happened. So it can be done. And the harmonization for the ICU would be like one step and then the bigger, but like a map with a goal and then some steps, some keystones that can be achieved, but taking on the table all the economic aspect and the specificity of the country.
Is the fact that the specializations are not properly defined in this way a result of the overall lack of resources, in the sense that because the resources are not there, the resources that are needed, you need to be flexible in a sense and have nurses who don't have the exact specialization being able to work in different areas?
Yeah, that could be an issue. It could also be the course doesn't exist. So the EFNA did the referendum of all the critical care course, and it goes to none to like 120 ACTS. So it's a master. So
we're talking about in some EU countries.
Yeah, it's
nothing.
Yeah, and some. So Europe would be like should be a nest for that to grow, and to that qualification of a master in critical care or something, to have that mobility within Europe, because now it's not the case. And so I think the approach would be to go to hospital law, saying, okay, if you want the ICU, you should have like one specialized, one advanced practice nurse also, one or two nurses assistants also. That could be something. If it's good, if it's well defined and the canvas is good, I think we can all work together, and we need to work together.
So you're talking about less flexibility between specializations, more definition there, but more mobility across EU countries.
Yeah, of course. Yeah.
What measures are you proposing to help address this nursing shortage or skills shortage?
I think we should have better declaration of incident. So it's still a big taboo for the safety and the safety culture to declare an event that's happened. I declare some things and I got a note in my file. So even though I followed courses on safety culture, I have to say, being honest, being Joséfine and not being an advocate, I sometimes have trouble declaring things, and I'm not always declaring things.
Is that because you're singled out and criticized when you do declare?
Yes.
And that runs absolutely contrary to safety culture.
Yes. And that's really something that pisses me off sometimes. So I know this is the right thing to do, but I'm not able to do it. And that's the same with the care that we can provide to the patient. That's really get on your nerves. And that makes you leave the job, I guess.
Now, is that something that SNO could address? Because it might be difficult at hospital level where this culture is not ingrained, but you could have an anonymous reporting system and then use that data to make reports. And make improvements.
on aviation safety, I know that you know quite a lot of on aviation, but this is something that needs to address. But what's also really been proven, we don't only need to focus on what's not working. And that's something maybe we can make a link to the image I had of nursing, is that it's a beautiful job. It's a magnificent job. I really love it. I'm really proud of being a nurse. But maybe we should declare what's working and how we did great job there to say, okay, if doing that is the right thing, then we need to really speak about it. If an incident happened, we need to figure out why and make it not happen. But we also need to have this positive approach and saying, okay, we really did good. Or with that machine, we had the example of when you are in the ICU, you have a lot of pumps with the syringes and stuff like that. So I had one like with the insulin, and then putting in the thing, I saw that it was not really what I wanted, and then, to make it short, the machine helped me not to make a mistake.
Sure.
But at first you say, you will have this machine, they'll have the... It's a little boring, but it's really helping you at some point. So, but saying, okay, the machine help, it's a good thing, then we could emphasize on it and start a good cycle, a happy cycle on positivity about work and the care we provide.
How do you see your career developing? Would you like to focus more on the advocacy side than you're already doing?
Yeah, I think so, because there's so much to be done. There's still so much to be done. And now it's going to make like 10 years that I'm in the ICU. The lifetime of ICU nurse is 7 years. So I'm already 3 more years. So that's nice. But it's not nice, but I'm laughing yellow, I guess. I don't know if it's the right translation for the for the sentence, but yeah, I'm laughing about it. But I think that's also an issue of nursing. You don't have really different aspect as a career. You're just a nurse, and then you can go chief, but it's not really a plus in your career, in my own opinion. You're in the administration and your team, and you can't really have autonomy. But it depends on hospital and there's management and stuff. But you don't have really evolution career.
Yeah. And you see the evolution?
Yeah, now I see
maybe within ESNO, within
advocacy. Now I see it with ESNO. I also, when I was in Dublin presenting the research and the nursing pool survey, we spoke with some of the nurses, and one of the nurses was doing some research on a sensor to detect epilepsy.
Yeah.
And then one came from Kenya, I think, and then we were like 3 nurses chatting, and I was like, did you ever in a million years, in your first year of nursing, would think that we'll be the 3 of us chit-chatting in Dublin about nursing and sensor and stuff? So this job is amazing, and we need to be the actor of it. And yeah, there's so many challenges that we can go there and we can address them and find solution.
So you within ESNO, you could help share this message about how invigorating and how exciting the profession really is.
Yeah, we need to be positive about our profession. It's amazing.
And what can you do to encourage nurses to speak up more about this, to speak more about this, but also to speak up about the challenges that they face?
Yeah. Believe in you, believe in yourself, in your strength, in your academic, and in your own ID. You see your patient, you know them, you see the problem in your hospital. There are some hospitals where they have nursing council, where they can have a place. They are elected and they can have like consultation for the boards to go and, we have an issue in nursing. What do you think? So speak up for yourself. If you don't speak up, it's like you want to have if you ask your sister to give you it's like when you try to make a present to someone and you ask their friends and you don't ask the person. If you never say what you like, what you won't get it. Say what you want and you'll get it. Verbalize it. It's like when you have a problem. If you don't say the problem, you don't have a problem. If you want something, say it. It's the first steps to get it. I think so.
I see a very strong advocacy career ahead of you. Joséfine, it's been an absolute pleasure talking with you today. Thank you for sharing your experiences.
Thank you, Paul. It was really nice. I really enjoyed it.
Thank you.